This is the recorded lecture for Chapter 6. We're going to do some highlights this afternoon after your test. But again, I just want to go ahead and record the lecture so you will have it to refer back to. Again, the first thing we're going to talk about is going to be some ethical concept. And as you see here, as we talk about ethics and give you a definition, it's basically the study of physiological belief about what is considered right or what is considered wrong in a society. In bioethics, it's used in relation to ethical dilemmas surrounding the healthcare. And again, you will be experience some ethical dilemmas once you get out in the workforce. Bioethics. I'm sorry. Then, as we talk about ethical dilemmas, this is basically a conflict between two or more courses of action, each with a favorable or unfavorable consequence. This is a dilemma, ethical dilemma. And again, you will be facing some ethical dilemmas in the hospital. You may, that with family versus the client or family um, versus the healthcare provider. But whatever the case may be, you're going to experience some. And based on there's some principles here, and you should have gone over those when you did your some of your engage assignments. It should have covered some principles, but the first one is autonomy. This is where we have to respect the rights of others to make their own decisions. We can't make decisions for a client unless they're not in their sound mind, and therefore, if they have a power of attorney, that person will make ethical decisions, make decisions for them. Then beneficence is the duty to promote good. And I clicked again too fast, but I'm talking about this principles of bioethics. And then again, non-beneficence doing no harm to the patient. Then you have justice, where you distribute resources equally, so everybody has a right to the same care uh, for the most part. And fidelity is basically maintaining loyalty, commitment, doing no wrong to the patient. If you tell a client, I'll be back in 10 minutes, try to come back in 10 minutes. And if you can't make it back in 10 minutes, when you can make it back, if they're like you may have had a dilemma, may have had a crisis or something, so let them know. But again, fidelity is maintaining loyalty again. And veracity, one's duty to always commit truthful. You don't want to tell a client if they're for a diagnostic test, just tell them the truth. Um, and you may not be in a position to give them results, but you don't want to tell them everything is okay when it wasn't okay. So again, these are some principles evolving ethical issues in sight, pharmacogenetics testing. Again, issues of non-beneficence. Again, if the tests are not useful, then potential harm outweighs the benefit. So again, also predictive psychiatry, stigmatization. We talked about that a little bit. Genetic testing could prevent individuals from getting a job. So that's stigmatization. And then taxation, issues of autonomy, right to know or not know genetics, tendency in healthcare, and then genome scan. So again, this testing is used to help identify the genetic testing, which antidepressant is to be used on specific patient based on their DNA profile. Okay. Hospitalization admission procedures, we kind of talked about this a little bit already. We've talked about voluntary versus involuntary admission. Again, a client that's in their sound mind may be admitted, or their guardians may have them admitted, but voluntarily rather. So involuntarily, on the other hand, it's without the client consent. Um, these are some parameters underneath there, which talked about where the client can be involuntarily admitted. And if they have a mental illness, they're not in their sound mind, if they're dangerous to themselves or others, also gravely disabled, but they can't make the decision, and in need of treatment and illness to prevent voluntary getting help. So again, involuntary versus voluntary, and like I said, voluntary client comes in on their own, and involuntary, they feel like they need treatment. So we have to, admit those clients. Involuntary commitment, again, emergency commitments, which could be temporary. The person gonna may be confused or demented. Also, they may present to the emergency room. Sometimes they are on a hold. Some facilities have areas designated to hold those clients until they can get a bed or something like that. So again, involuntary or emergency commitment, we use for observation, like I just said, diagnose and treat. And generally, it's anywhere from 24 to 96 hours. And before they are discharged, if they've been admitted involuntarily, before they are discharged, you have to get a court order um, before they can be discharged, okay? And make sure they, again, if they're going home, um, then make sure that they follow up with their healthcare provider. Some clients may go from like a involuntary admission, they may go to long-term care facilities. So just again, it's with that being said, there are two ways: voluntary versus involuntary. And I've seen a lot of both, based on my experience, involuntary and voluntary that presented to the emergency department. And this is an audience question here: which individual may need involuntary hospitalization? And the answer is C: an individual with bipolar disorder, manic, who has not eaten in 4 days. The reason that C is correct, I'm sorry, it's because if somebody has not eaten in 4 days, they're going to be at risk for what? Malnutrition. They could be at risk for electrolyte imbalances. So that will be the client that will need, and that refuses to come in. So if we know if that client doesn't eat, they're going to have some physiological problem. So again, involuntary commitment for those clients that are ill. They could become gravely ill, and with this client here, in this situation, this client can become gravely ill by not eating. Uh, Writs of habeas corpus. This is a due process. A client, although they're going to be admitted involuntary, um, we still have to. Sometimes it's very challenging. So therefore, we have to make sure the client is assessed for the most part. So with this being said, which the writs of habeas corpus, meaning that a formal written order to free the person, they can't come out of the hospitalization or rehab or whatever unless they got a court order to do so. So those clients that feel like they have been held without just cause, again, they still have rights. They have a right to file a petition for the process, which means they have to have a formal written order to let them go. Then you have least restrictive alternative doctrine. We kind of talked about it in class. You want to use the most least first. Again, de-escalation. Then you go to medication. Then you move on up to restraint if that's the case. Okay. But again, it's whatever method we use is going to be the appropriate method based on meeting the client needs. Discharge procedures, unconditional release, meaning that a client can, if they've been admitted, they can go be released without any restraints. Meaning that if they are required to do follow up every week, whatever, they have to show proof or show up to those appointments. So they are released contingent upon that they will follow the order. So again, if they don't do it, then they could be institutionalized. Then you have also AMA. A client has a right to sign out AMA, but again, if they're involuntarily admitted, they really can't sign out AMA. They have to have a court order to do so. But in the other hand, if they come involuntary, they can leave at their own will. Now, AMA could present an ethical dilemma for the clinician because the client trying to go, they pack up, I'm leaving, so it could be, well, we may have to call security if those clients on a mental illness hold. So that could be an example of an ethical dilemma for a clinician. On the other hand, clients they have their autonomy. They have the right to refuse treatment, support the patient wishes for discharge. Again, if they're on a hold, you know, we can't let them go. And then again, they have a right to refuse medication. Now, if they're stabilized and they refuse medication, we can't make them take it. However, if they become um, hostile, irate, or whatever, threatening the environment of themselves, then again, we have to medicate them where we have to get somebody to restrain them and medicate them to calm them down. Then you have conditional release, usually requires outpatient treatment for a specific period of time. The follow-up again, conditional release, going back to we talked about unconditional release, where they, I'm sorry, maybe I said it wrong at the beginning, but unconditional release meaning that they can go home not having any restraints. And then again, conditional release is when they require that the client follow up an outpatient during a specific time to be constantly evaluated, maybe therapy, whatever the case may be. So that's the difference between the two. Then again, by law, these clients, again, you go back and look at the patient rights. They have the right to refuse treatment, right to treatment, right to refuse, and right to inform treatment. Uh, Patient is informed of the risk, again, let them know what the risk, the benefits, and alternative are. They must voluntarily accept the treatment. Also, implied consent. This is a patient who approaches with a medication, and you can approach a patient with the medicine in your hand. The patient indicates willing to receive the medication. So again, if they willingly, they don't have to say, "Yes, I'm going to take my medicine." Willingly, if they take the medicine and then get it put in their hand and they take it, that's a form of implied consent. Because they are actually taking the medicine. Capacity basically is a person ability to make that informed decision. Going back, can they make that informed decision? And competency, basically, this is a legal term related to the degree of mental soundness of a person. So they have to be competent to make specific decisions as well. And then the next thing on here is a case study. This is a client that was admitted by the court to your unit with a diagnosis of paranoid schizophrenia. Her lashes, he lashes out on the staff when they attempt to give him his medication. He states, "You are trying to poison me." At this point, he continues to argue with the staff. He's not aggressive, but refuses to all treatments. Legal rights are suspended when a client is hospitalized voluntarily. Is that true or false? So the answer is B, it's false. Involuntary remission requires that the patient retains freedom from unreasonable body restraints. They have the right to informed consent, and they have the right to refuse medication, including your psychotropic and antipsychotic medication. Otherwise, the rights are preserved. So the answer is B. So the family asks if you can force him to take the medication, how should you respond? So again, if there's a court order, you have the right to medicate this client. The patient, you have a right to medicate them if they have a serious mental illness. If you notice that the client condition is deteriorating, we talked about that client that had not eaten in 4 days, or suffering from exhibiting major life-threatening behaviors. So whenever the benefits outweigh the harm or the risk, we have to medicate. And then the person lack capacity to make decisions about the treatment. So again, this client cannot make the decision about the treatment, so you have the right to medicate. But of course, we're going to use the least restrictive method possible. So these are just some patient rights under the law regarding psychiatric advance directives. You have when there are times when we may have to restrain, but make sure you follow the orders. You have to document intensely on these clients. In an emergency situation, the nurse may place the patient in seclusion, or restrain, but they must get a written order or a verbal order as soon as possible thereafter. So a client coming in acting out, you have the right to go ahead and restrain them. Orders for restraints and seclusion are never written as needed or standing order. The client has to be reevaluated, and those orders have to be rewritten. So you can't just go by, "Well, I just got an order." The order has to be rewritten. And I think, but based on the time frame, you follow your agency policy telling you how long those orders are effective. Patient right under the law again, patient right confidentiality. We know we have to maintain confidentiality. Also, restrain from social media, giving putting information out there. Confidentiality after death, a person still have the right to of their confidentiality, although they are deceased. And then also confidentiality of professional communication. So when you talking about a client, you only want to talk about those clients that have a need to know. Meaning that if case managers will have a need to know about the client, but just general conversating about a client to someone that does not have the need to know, it will because it will violate those clients' right. Exception to the rule as far as confidentiality, you have the duty to warn and protect the third party. We are mandatory reporters for child and elderly abuse reporting. Failure to protect the client, we have to make sure we protect the client. And an example of duty to warn, if a client tells you that I'm going to do harm to the nurse that's coming on, you have a duty to warn that nurse. So if anybody tell you that they're gonna do harm to another individual, you have the right to warn that individual. That's what that means. Okay. So again, we are mandatory reporters for child and elderly abuse. Eventually, JS agrees to ECT, which member of the team is responsible for obtaining the client's informed consent. So again, ECT, you are responsible for making sure that the consent is signed as a nurse, but the physician is responsible for getting the consent. You can witness it, but it's that whoever's going to do the procedure, that physician is responsible for getting the consent signed. And you can be a witness, but you're not responsible for getting their consent signed. Tort law is basically any wrongful act, intentionally or accidental, that result in injury to another. This falls under the tort law. Intentional tort, willful or intentional acting that violates another person's rights of privacy. Again, you see some examples as far as assault, battery, false imprisonment, invasion of privacy, and defamation of character. These are some examples that falls under that tort law. Anything wrong is any wrongful act, again, intentionally, accidental, that results in injury to another. And then also unintentional tort is unintended acts against another person that produces injury or harm. And under that unintentionally falls negligence and malpractice. Okay. There are some 5 elements to prove negligence. Duty, did you perform your duties based on your um, standard of practice, nursing scope of practice? Breach of duty, cause in fact, basically this is sometimes known as actual cause, may be evaluated by asking the question, if it were not for what this nurse did, then or failed to do, would the injury occur? That's what you want to ask. If I had done this, or if I didn't do this, did it cause an injury to occur? That's basically what that means. Proximate cause or legal cause is determined by whether the event was foreseeable, meaning that it could have been prevented for the most part. As we talk about State Board of Nursing standards of care, we have to follow your state board, um, your scope of practice. Also, professional organization, they evaluate the practice and its members by setting standards of excellence. Again, professional organization, you have professional organization like Mental Health Association, and also like you getting certificates for professional development. This falls under professional organization. Institutional policies, procedure, I can't stress that enough, because at the end of the day, a institution can strengthen a policy based on the Nurse Practice Act, but they can't weaken it. Nurse Practice Act may say that you're gonna do um, renew your orders every 12 hours. I mean every 36 hours. Hospitals say we're gonna renew those restraint orders every 24 hours. So always remember that whatever your agency policy suggests, that's what you have to do. Custom as a standard of care basically can be used as evidence of a standard of care. In the absence of a written policy on the use of restraint, temporary testimony may be offered regarding the customary use of restraint in the emergency situation. What do you customarily do? However, you're doing this to prevent harm. Those clients that can become combative, violent, that poses a threat. That's a custom as a standard of care. You have to do something to protect the rights of those others. Okay, this is a question here. It says, which of the following identified that the title that registered nurses will use and what they are legally allowed to do? And then again, you're going to follow your state board of nursing. Uh, Acting on questionable practice, again, negligence, it being irresponsible or impairment. Sometimes we talk about nurse impairment, like they may have an impairment, like drug abusers. So again, we have to look at were that nurse under the influence of alcohol or drugs when they did something that was negligent. Duty to intervene and duty to report. And we are required to report incompetencies, impairment, or criminal activity. Again, if you're working with one of your peers and it appears that they are under the influences, you have a right to report. The reporting process to present actual harm, document clearly factual information. You can't make assume. You got to document the facts. Make sure if you notice that you document it, you notify your supervisor. So again, we can't let a nurse that out there that have an impairment take care of the patient because guess what? That's something foreseeable. So they could cause harm to the patient. Then again, documentation of care. I can't say that enough. You have to document accurate, complete, means of interpersonal communication. This is where your SBAR report comes in. Teams meeting. You collaborating with everybody on the team that's involved in that client's care. A patient have a right to review their records. They do. They have a right to review them. Although the records belong to the institution, but the clients still have a right to review them. As we talk about medical records and quality, retrospective record reviews, you have quality improvement of quality care team uh, that are responsible for looking at the records, making sure that they're used for quality improvement, used for as evidence, used for risk management purposes, and used to determine insurance reimbursement. So somebody's going to be looking at your documentation. So make sure it's accurate, concise, and specific to your client. Records are used to determine medical records, the extent of the patient damages, if there's a claim or a suit filed against you, so that they look at the documentation. Uh, did we put the bed alarms on to prevent the client from falling? Did we put them on skid resistance style? Whatever the process is, your policy say do, or if you know that this client is at risk for falls, what did you do to intervene before to prevent the fall? You have to document the nature and extent of the injuries in abuse cases, the nature and extent of physical, mental abuse for the disabled clients, and also nature and extent of injury and rehabilitative potentials in working compensation care. So again, those are some basic guidelines. How important it is at the end of the day, you have to document. Guidelines for electronic documentation. Again, that electronic documentation. I'm sure some facilities, all facilities that I know of lately, have gone to electronic records. And what they do, they just manage the data and communication. Also, electronic documentation also help decreases medication errors, and then help facilitate decision making. And if there are federal guidelines that the electronic health director fall under, court assumes that if it's not documented, it is not what done. So we need to document specific rules and time frames for correcting errors. If you make an error, you need to correct it immediately. Okay. So again, these are just some guidelines for electronic documentation. I just want to share, and I'm sure all of you know this, you're not to share your password with anybody. When you leave your computer, you need to log off. Again, so just FYI, I'm sure you've heard this more than one time. Let's talk a little bit about forensic nursing. You may hear the term forensic or sexual assault nurse examiners. The acronym for that is SANE, S-A-N-E. But however, it's the application of principles in a court of law to assist the decision. So again, if somebody has a case They may call in that forensic nurse as an expert to be a witness. Nurses often educate the court on the science of nursing, like I said, and may provide opinions and using appropriate guidelines for standard. So again, they may call that nurse in because that's his or her expertise to be like an expert witness. Also, with forensic nursing, there are issues at stake, which may include patient competency, individual fitness to go to trial, and then involuntary commitment, then responsibility for a crime. So again, forensic nurses, again, as we talk about sexual assault, I'm going to be bringing it up again. Forensic nursing or sexual assault nurses, they are, if there's a rape, they are responsible for doing the rape kit, okay? Because the rape, collecting that evidence is critically important, and again, it has to be preserved. You have to go to court. So again, like I said, your record's going to be there when you get there if you're subpoenaed to court. So make sure you document appropriately. Violence in the physical psychiatric settings. Also, nurses must participate in setting policies that create and maintain a safe environment. Also, always document the patient potential for violence. Or they may not be violent, but they may have some potential of becoming violent. Then communicate to your colleagues. Like I said, rounding, team meetings, and SBARs is a good way. New laws also enhance criminal charges and penalties for striking nurses and other healthcare workers in the course of duty. So again, got to make sure you know what if you're not working in the state of Alabama, whatever state you're working in, you must know your parameters there when you come to striking. And again, like I said, if you're on duty, if a client strike you too, there's some, there's a process we go to. That client can have some criminal charges also. Then the last one is another little audience question. It said the nurse was a case manager for a client with serious mental illness for 6 years. The nurse died by suicidal 1 week ago. Today, the client spouse asked, I always wondered if my spouse was a victim of sexual abuse in childhood. What can you tell me about that? Can the nurse disclose information to the surviving spouse? And the answer is no. Again, when I said early on that the deceased client, they have rights as well. All right, that ends chapter 6, and I will try to get it uploaded. I have to create a YouTube to get it uploaded, but I will do that.